So now we move into, I guess, the second session of the morning. And thank you for making my job much easier by introducing each of the panelists here. We are indeed privileged to have this extremely distinguished panel today. And all of them, Professor Mehrotra from JNU, Mr. Dutta from the Capital Group, and Nachiket from the Bill and Melinda Gates Foundation. The three of them put together have far, far more wisdom than you can think of. And that is the second reason why my job is very easy today. I don't need to get into anything or speak anything. They'll do all of it. I'll only play a little spoilsport in between in reminding them what really it means as far as the Indian context is concerned. Because perhaps that is one perspective I can bring it to the conversation. But you know, if you look at the subject that we have for the panel discussion, it's, it may say whatever. What effectively it means is that let's discuss everything. Because you actually are talking about a challenge that lies ahead in the healthcare scenario in this country. And when you start talking about challenges, it cannot be limited to what we do to the out-of-pocket expenditure or what we do to the access, etc. But it's actually hitting out at the very base, although I have been given a paper to suggest what each of the panelists must concentrate on. But if you look at the overall scenario, and we look at it in the context of how does India work to get the best out of its population, the dividend that we keep talking about, and one of the critical platforms that need to be created to get that dividend is a healthy society. Not necessarily, as I always keep saying, a society, a population which we have the ability to cure, but a healthy society. And perhaps that is what the health systems in India need to moving on. I guess I will not get into any more details, and hopefully I'll have a little say at the end of the discussions. But just to make things finish in time and keep on time, I would request the panelists to take over. And I would start with Professor Mehrotra. And the issue that we are posing to you, Professor Mehrotra, is how crucial is health as a fundamental building block to the entire concept of growth and development?
No issues. So I'm going to address very much the issue that you have raised. And as it happens, this is a subject that I have just finished writing on, and it's a paper that's forthcoming in the International Journal of Human Development and Capabilities, and the title of the paper is absolutely spot on this very subject, and the title is Economic Growth and Human Development in India, Are They Causally Connected Between 1993 and 2014? And I'm just going to sort of, very quickly read out to you the abstract of the paper so that, there's a huge amount of data analysis at the state level that has been done by me and my co-author over that nearly 25, well, it is actually a 20-year period. And the conclusion that we come to has direct relevance to what this panel is about. The major findings of the paper suggest that in these 20 years, the Indian economy's unprecedented growth rate has brought a substantial improvement compared to 1993, a substantial improvement in the Human Development Index, but which is mainly due to the reduction in the incidence of income poverty and the improvement in educational outcomes. At the same time, growth itself has been positively impacted by the reduction in income poverty and the improvement in educational outcomes. However, due to a weaker causal connection from growth to health and from health to growth, and government intervention is warranted to improve health conditions of the poor and marginalized groups. Based on very rigorous econometric analysis, we conclude that ensuring inclusiveness through growth in health outcomes would not only sustain output growth further through increasing labor productivity, but would also help improving human development outcomes through reduction in income poverty and through the improved level of skill in long run. I just want to also cite our own Human Development Report, which is only the second National Human Development Report for the country, which we did when I was in the Planning Commission. It was very interesting that we found that over the period from the year 2000 to the year 2012, the Human Development Index, as I've just said to you just now, improved very significantly. But then you know that there are three components, and I spoke about those three components. It's income, it's health, and it's education. But what we found was that what was driving the income growth, the HDI growth, was income growth and educational outcomes, which improved by 26 and 40% respectively. But health improved only by 14%, which in other words was pulling back the HDI. So we may well ask the question, in other words, I'm citing you two solid pieces of work which seem to suggest that we are failing our population catastrophically with vast consequences across the economy on the rate at which we manage to reduce poverty, on children's learning ability, quite apart from economic growth itself. So where are the problems? To me, the problems are twofold. One, in the health sector. I'm now homing in straight away on the health sector. Twofold. One, we are quite happy with spending too little on health. In other words, the government has been systematically quite happy with spending too little, and is still quite happy spending too little, because at the present moment of time, it is spending 1.15% on health, public health, as a proportion of GDP, which is among the lowest for any country in the world almost. The implications are obvious for out-of-pocket expenditure and the functionality of our health system. And the tragedy is the National Health Policy just came out earlier this year, and we had huge hopes about this particular subject, but which were dashed to the ground, tells us that we will work towards moving public expenditure on health as a proportion of GDP to 2.5% of GDP by 2025, 8 years from now. In other words, in 2025, we will be still spending less than what China was spending 10 years ago at higher per capita income and at better health outcomes 10 years ago. That's what our government, that's how much priority the government believes health needs. Let me fast forward very quickly to my second set of points, because these were all macro points. I'm going to make some micro points based on my recent experience of attempting to understand the UP health system. I'm a UP wala. I'm currently helping the UP state government, thanks to Global Health Strategies, design a state health policy. Very good news that, the new government has decided to come up with a state health policy. I have been discovering, to my utter shock and dismay, that, in all other states, there are the health sector has two departments. This was in the wisdom of the central government. In about 15 years ago, the central government, sent out instructions through notification that the health sector must be split between medical education department on the one hand and the public health system on the other. Until the early 2000s, until 1500, there was only one. That created, of course, a great deal of dysfunctionality on account of the coordination failure, which I will speak about in a minute. But UP has the unique distinction of having split it into three. They split even health and family welfare and put health, family welfare into another department, and they have a principal secretary for family welfare, a principal secretary for health, and a principal secretary for medical education. And then, of course, like with all due respect to Mr. Mishra, departments in no government, in any state or in the central government, like to talk to each other. But let's take this a little further. David Wilson in the previous session talked about the success of, so you can imagine that the constant dysfunctionality which results from having three departments looking at basically similar issues, which works all the way down. I'll come to that in a few minutes. But imagine on top of all this, you have a country which has roughly 28 vertical programs, vertical health programs. HIV/AIDS was one success story, or however many there are. The point is, if you have more than 5 national programs, you already have a basis for dysfunctionality. So Wilson talked about the functionality and the effectiveness of one. And then he simultaneously talked about TB. But then there are so many other national vertical programs, all of which funded from the central government, which are not particularly integrated into the public health system in the state, which might be co-located, but the point is their money is coming from there, their reporting is like that, and you can understand how effective that is. And you can understand also what the implications of this are at the local level. But let me take this a little further and just speak a little bit about what is the degree of sort of dysfunctionality that results from the fact that the health department itself has 5 separate institutions, which must talk to each other if you're going to deliver anything worthwhile. So you have the National Health Mission, you have the Health Directorate, you have the State Institute of Health and Family Welfare, you have the SIFSA, which is sort of family planning, and perhaps there are 1 or 2 others which I'm even forgetting. And I'm aware, and it was obvious to everyone, as well as to the Secretary Health in UP, that the departments don't talk to each other. There is always a constant struggle going on between the Health Directorate on the one hand and the National Health Mission, which is where all the money is. The money is coming from the center for that. And in fact, the problem has gone so far about 3 or 4 years ago that chief medical officers belonging to the Provincial Medical Service were so dying to become CMOs of the National Health Mission structure, as opposed to the normal CMO, that there was a war going on, outright war. People were killing each other, people were in jail and were being killed in order to ensure that they get access to that great job of the CMO National Health Mission. Please notice that I have so far not even mentioned coordination or coordination failure between these 3 health system verticals and the interventions that are needed in respect of the social determinants of health outcomes, and I'm thinking obviously of nutrition and of water and sanitation. I haven't even mentioned the local panchayats or the panchayati or the ULBs, which ideally in any situation like this should have a role. When I had a long conversation with the district magistrate of Lucknow, who had spent being district magistrate in at least 5 other districts and one of the most outstanding 35-year-olds that I had met, he was effectively shedding tears. He says, the system is so grossly dysfunctional and that expecting anything other than Gorakhpur, and if you read these today's newspapers, you've seen exactly what has happened. And I will close with the following point. That the Comptroller and Auditor General about just a few months ago had, in analyzing the medical colleges of UP, noted that, all of them had serious shortages in terms of clinical equipment, and it says that BRD, Gorakhpur, had clinical equipment shortages of 56% and non-clinical equipment shortages of 27%. Now, that's on the equipment alone side. Can you imagine how money flows in all this situation can actually complicate the situation? Money flows are complicated because you have this structure of health delivery that is designed to fail. Then if it is designed to fail, then it fails. Why are you surprised? Thank you very much.
Thank you, Professor Mehrotra. Thank you for that extremely insightful enunciation of how the health systems are being run in the country. Some of it coming from an academic analysis, a bit of it also from field realities. There are many issues that Professor Mehrotra has raised, which, as we go along, I guess the more knowledgeable in this room will take on. The thrust of what was being put forward was that it is government which has not been able to run a system. I do have an hypothesis which I keep sharing with everyone, that it is not the business of government alone and should not be the business of government alone to run a health system in a country. We'll have a little more discussion on this as we go along. But just a couple of quick issues relating to, very often we miss the larger point of inequities in India when we compare health system of one state to another. And many of us he of course has done a great amount of work, but many of us would generally, by looking at one state or the other, conclude about the health systems in the entire country. The creation of a public health and medical education separation is a function of the Constitution, one being a state subject and the other lying in the concurrent list. But that has not prevented many of the states in the country to keep both together. So there are many kinds of examples which we will talk about, and hopefully I would like to raise certain issues on what Professor Mehrotra, but extremely important point that he made was that unless we are able to run a coherent system that is bound within itself and speaks to each other, we may find it difficult to run a better health system. So more on it later, but let me just quickly move to our next panelist for the day, Mr. Anirudha Dutta from the Capital Group. And Mr. Dutta, we would like you to talk a little on the issues of gender. We keep discussing, how to address gender-related issues. But before I request you to speak, let me tell you that this is a very critical issue as far as healthcare delivery is concerned. Not so much in terms of attending to gender issues in hospitals or health-like facilities, but more so in the very health-seeking behavior of the population, or the kind, for example, in a family, if a man and a woman is sick, who gets the priority for healthcare. We have these issues, and these are again issues which a hospital system cannot really decide or manage. Larger issues where society will have to get in. But then, if we want our health indicators to really improve, gender is an issue which we need to seriously address. So over to you, Mr. Dutta, to talk about addressing gender issues.
Hi. Good morning to everybody. Thank you, Mr. Mishra, for that introduction. And thank you, ORF and the Gates Foundation for inviting me here. Before I start, a confession to make. I'm probably one of the least qualified people to speak out here among the various panels throughout the day, because my full-time job is neither in healthcare nor in gender issues. I'm a financial analyst and probably the only speaker who has come from Mumbai out here or outside of Delhi. Having said that, I'm probably here by virtue of the fact that I wrote a book on girls and women in India, their education, empowerment, etc., tried to weave through a positive narrative in spite of all the news, etc., that we see all around us day in, day out. So the topic given to me, as Mr. Mishra said, is address gender-related issues for growth and development. And I'll have two parts to my talk out here. One is, why is it important? And two, therefore, what can we do about it, or what can the approaches be, as I see it from a layman's perspective or an analyst's perspective. First, some numbers. 588 million people women in India, and 30% of them are below 15 years of age. When we talk of demographic dividend, and earlier speakers have spoken about it, 48% of the below 15-year age population are girls and women. Now, therefore, there is no demographic dividend if the health of the population is not good, if the labor force participation of girls and women doesn't go up in the country, and we don't have more equality, whether it's in health, whether it's in education, whether it's in employment opportunities, whether it's on safety of women or what have you, any number of issues. There is just no demographic dividend. And if maternal health and the girl-child health are issues, and there's inequality out there, then how will we skill people? We keep talking about education, and we have done a remarkable job in getting, between the age of 6 to 15, almost 100% of children who should be in school, we have got them into school. The outcome of that is indifferent, is distressing, but at least they are attending some form of school, they're learning something. Now, how do we educate? How do you skill? And there's a lot of talk that goes on about skilling of people. We have tall targets for skilling by 2020, 2025. How will that happen if our population is not healthy, whether it's mentally or physically? And that cannot happen if the maternal health is not good, if the girl child, who is 50% of the population, is not of equal health as the boys, and the boys themselves are stunted if the maternal well-being is not there. Therefore, it's very important to talk about gender issues when we talk about health outcomes. And some of the numbers are distressing. While we aspire to be a superpower, and it sounds exciting, and you feel proud to be an Indian when Yuri mentioned our various achievements and where we punch probably above our weight, but the one area where we really punch above our weight is in statistics which are dismal, which is about Human Development Index, which is about literacy rate, it will be about health outcomes. And for example, we are about 17% of the global population, but 22% of global maternal deaths, our share in that is 22% in maternal deaths. Our share in newborn deaths is 27%. And one can go on. We, in these indicators, are actually below many African nations. We are below Bangladesh in most of these respects, and sometimes even below Pakistan. Two countries which are not really necessarily known for either women's empowerment or necessarily being more sensitive to women's and gender issues. Therefore, what does this mean? Often more childbirths therefore happen among the poorest of families, and a vicious cycle of poverty and poor Human Development Index just continues. The second factor that I wanted to highlight is it's a reality, and I think one of the previous speakers spoke about it, the huge discrimination between, when it comes to the girl child and women, when it comes to whether it's food, whether it's come to education, whether it comes to even healthcare. Now, again, consider some numbers, and these are from Haryana, which obviously has the country's worst gender gender ratio. Child mortality between the age of 1 and 4 years. The ratio of female to male child is 2.16. More than twice as many girl child die than boys. The all India average is not very encouraging, it's 1.47. Across states, female child mortality is higher than male child mortality. Someone mentioned stunting. The proportion of stunted girl to boy is 2.12. And when this study was done, this is Haryana. And I'm quoting research which is available on public domain. Many of the biases will actually be even difficult to measure, although some researchers doing household surveys have tried to quantify it about less medical attention being paid to the girl child. Rushing a girl child to hospital after a far more prolonged illness than you would do to a male child. And there's enough evidence about that. There's a study which showed that healthcare expenditure on females was systematically lower than males across all demographic and socio-economic segments. And this gap was actually not due to differential distribution of factors affecting healthcare, like, for example, education or poverty, but actually there was systematic discrimination against the girl child. And this goes on everywhere. The girl child is less immunized than boy children. They have less access to hospital treatment, subject to fewer hospitalizations before death. And, and the same thing is available in the education sector as well. Less number of girls go to private sector schools, where private sector schools are supposed to have, expected to have better outcomes, although as studies have shown there's really no better outcome. The third factor that I wanted to highlight was social practices. For example, 47% of girls get married before the age of 18. Now, between the age of 15 to 19, a woman is twice as more likely to die in childbirth than between the age of 20 and 24. If it's below the age of 18, then there's a 5 times more likelihood of death of the girl. Now, early household responsibilities, early marriages, early motherhood, then less education, all this drives then an outcome which we know what it is. Therefore, if we talk about gender-related issues on health, care and better outcomes, it's not just about equal access to healthcare facilities, it's not about no discrimination at home, but it goes more beyond that. It's about stopping child marriages. It's about access to water closer to home. It's about toilet availability. It's about work available probably closer to home with flexibility, adequate and safe transport. I mean, as one study showed, while Janani Suraksha Yojana, etc., have done a great job in increasing institutional births, while financial incentives are important, but also what's equally important is transportation, for example, availability of transportation. It's about the comfort level that the woman feels. Does she have enough help at home to take care of older child if there's an older child? Otherwise, how will she go and give birth in an institution when there's probably a 1-year child at home? In conclusion, therefore, I've addressed the why issue of why gender issues are important and need to be addressed. I would like to leave you with 5 points about what I think could be the approach or issues to think about. One is, beyond access and beyond physical infrastructure, I think socio-cultural and socio-attitudinal changes are very important. And here is just not about the male mindset, but also the female mindset, which has got conditioned over generations. Otherwise, just literacy and education or prosperity cannot help. And we can see that in, for example, the gender ratio, where prosperous states have more adverse gender ratio than probably some of the poorer states. And data is available, for example, that systematically shows more literate women have actually less male child than probably in the poorer sections of the society. And again, that becomes better access to certain facilities. Similarly, better access to facilities and reduction of out-of-pocket expenses will help in better gender equality in healthcare. And an interesting idea that was mooted, I think, some years back, and Nachiket has been talking about a fair bit, if I remember, in his writings as well, was to have this 3.5-year qualification of doctors, the non-physician clinicians, or the Bachelor of Rural Healthcare. Now, I remember when it, at least when I read about it in the public discourse about 2 or 3 years back, there was a whole lot of opposition about why the poor in rural areas should have poorer healthcare. The fact is, look at the alternative that is there. And when I spoke to my driver who hails from Jaunpur, he says, "Hamare wahan to jhola wala doctor hote hain, jhola wala doctors." And I hadn't heard the term, so that's my ignorance living in Bombay. And it turns out, therefore, the compounder becomes a doctor basically. And he told me he can give glucose, he can give medicines, he does basically everything because that's the only help available. it's much better outcome that will be there. And I think Maharashtra, I was reading a study which has seen much better outcome. In 2019, it started recognizing these diplomas from the College of Physicians and Surgeons. And about 1,000 specialist medical officers who were not MDs, and not MS, but had just diplomas. And Maharashtra by 2013 has had made the best progress in reducing maternal mortality from about 144 to 68. It's actually very close to Kerala, which is at 61. It's better than Karnataka, it's better than Tamil Nadu actually, which earlier used to be much better. The third point is spend is important. I think Dr. Mehrotra spoke about it. But as a poor country, we have to spend effectively. And that's not possible unless there's better governance, better transparency, and better accountability. And probably some of the technology factors which some other speakers would address would talk about how accountability can be improved or transparency can be brought in. But look at Gorakhpur. We get outraged when there is Gorakhpur or any such incident, whether it's about rape, whether it's about healthcare disaster or whatever. But it's not made into the national media that in the last 1 week there have been 30 deaths, child deaths again, in the Mahatma Gandhi Medical College in Jamshedpur. I discovered it because I was in Jharkhand in the last 2 days. It doesn't even make into national headlines. It's same as Gorakhpur. Gorakhpur was probably closer to Delhi and has had a new chief minister. So it probably made more noise. Why do states like Tamil Nadu or Maharashtra or Andhra Pradesh or some of these states have consistently better outcomes? The public spend probably is higher in the other states, but it still doesn't get better outcomes. And there lies the core of whether it's governance, whether it's about coordination between institutions or the structure that is, and other issues which for someone else to debate on. The fourth point is understanding real life issues means there won't be one size fit all solutions, to my mind. And what brought this point to my mind was a woman CEO from an organization in Mumbai telling me that she had proposed a creche in her office. And to her surprise, all the women in the organization came back and said, we don't want a creche in the premises of the office. And she was surprised, and her office is in Worli, Midtown, Bombay. And the women told her, look, you know, you come from close by, you drive in a car, you are the CEO of the company, but we take the train. We cannot bring a 1-year-old child in suburban Mumbai train. I mean, the child will be crushed to death. And anyone who has taken a train would know. And for any distance in Mumbai. And therefore, there are issues like this. My last point is, and I think that's been again touched upon earlier by one of the speakers, is break down the silos, break down the walls, because there's a holistic approach necessary. It's just not about healthcare. It's just not about the Ministry of Rural Development. It's not about Ministry of Human Resources. It's or Ministry of Skill Development. There has to be a across ministries, across department solution. And finally, all solutions, at the risk of coining an acronym, which we probably have too many of them these days, is, and I spoke about it a long time back, was, I call it S2R. Any solution in this country has to be scalable, has to be sustainable, has to be replicable. Because otherwise, again, we'll have good success stories, but to impact 1 billion people, you need scalable, sustainable, and replicable solutions. I'll stop here, and thank you very much.
Thank you, Mr. Dutta. Thank you for that extremely lively talk that you gave. Brought out many issues which many of us here in this hall have been discussing for a long time, and some new insights as well. Yes, indeed, unless we are able to address the gender issue, the demographic dividend is not there for us. 253 million adolescents, more than half of them, or close to half of them, are girls. Unless we are able to address that, I don't know where the health systems will go. But just one issue which you highlighted about the maternal deaths and the infant mortality and the child deaths, very critical, very, very critical to the Indian healthcare system. And we are still long way from achieving what we should have done long time back. But there's another story to it, and I'm just placing it for consideration of the audience. Yes, we contribute the largest. But if you look at the story of the last 8 years or so, 2008 onwards to be more precise, the decrease in under 5 mortality or in maternal mortality and the rate of decline in India is much, much faster than anywhere in the globe or even the global average put together. That is not to say that we are there. But what I'm trying to say is that a storyline has begun and we will soon see results. And this brings me to your, other point, which I always find a very interesting point of discussion in front of people who know so much about health systems. Maharashtra, you mentioned, did not invest as much in health as some of the other states. Still had very, very focused results. So it brings us to the larger issue that while it is very, very critical, and Professor Mehrotra, I'll take your point at this, to increase public health spend, 2.5 or whatever we can continue to argue. But is it only about more money for health? Or is it also about more health for the money that we spend? And this is a point, as a country, we need to keep in mind. It's not always possible to garner all the resources that you really, really want to have. You made an interesting point about the coverage on Gorakhpur, etc. I don't want to get into this issue. It's a very, very sad chapter which should never be opened again. But I have a question. And I hope it's taken in the correct perspective. Unfortunately, the rate of deaths of neonates in that hospital, and the average daily is about 10 to 11, which is extremely, extremely unfortunate. But yes, it grabs eyeballs, it grabs media attention. We see very little written on the fact that we lose 44,000 pregnant women during childbirth every year in the country. Or for that matter, that we lose 11.5 lakh children before the age of 5 every year in the country. I'm just throwing this question because these are issues as a country we need to debate as to what kind of a healthcare system are we trying to build for ourselves. But thank you very much for having brought these issues out. And we'll now move to our last panelist, Nachiket. The subject for you, Nachiket, is something that you've been talking about all the while. So I think you have been in it for a very long time. And I did mention in the beginning that health cannot be a business of government alone and should not be. So what is it and where is it that we need the private sector? What is the ideal mix of public-private investment in health? And also, if you can, I'll add a question to that. Where should it ideally lie? So Nachiket, over to you.
Mr. Mishra, thank you very much for posing this very important question for me. Mr. Dutta, Professor Mehrotra, it was wonderful to listen to your the issues that you've raised. What I'm going to do, sir, is with your permission, talk about two issues. One, two, and many speakers have done this already, but I want to emphasize it again. Why do we need to worry about health? Because, we are a very poor country. People would argue that we should focus on growth, we should focus on jobs, we should focus on issues that matter to us. And there are interesting statistics in which people argue that it's not a political priority, which is one of the reasons why a country like Thailand went from 1 or 2% to now almost 6 to 7% of GDP is in health. We are still in the same ballpark where we were in the 1950s. Even our high success story states, Maharashtra was mentioned, Kerala was mentioned, Tamil Nadu was mentioned, they're in the 0.9, 1.2% type number. There is no state, there are a few states, smaller states that are doing more than that. Why is it that health is therefore important? And why would somebody like Mr. Dutta, for example, not wearing his gender hat, but wearing his capital markets hat, worry about health? He might say, well, as a person interested in the women of India, I'm interested in health. But as a capital market player, I don't really care about health. It's not a big issue for me. But I would argue that perhaps there are linkages that we are not actually seeing as much. And I just want to trace them a little bit. And then talk second about the whole private sector issue and what can we do about it. Health, I would argue, has two linkages to this challenge of poverty that we are seeing. You know, we are today the country that holds perhaps the largest number of people below the poverty line on a global basis in an absolute sense and perhaps even as a proportion relative to the population size that we have. One is the expense direction, which is relatively the obvious direction that you see. Even in the introduction, you see a number of 60 lakh individuals going below the poverty line every year because of this. It translates to about 4 to 5% of the population going below the poverty line every year. In a country where we are trying very hard to take that number of 25 odd percent to bring it down, if you start every year with a handicap of 4%, the job becomes that much harder. I'm told in China, this visible fact that its attempts at growth were being retarded and its attempts at poverty reduction being retarded because they were pulling many people out of poverty, but a large number were falling back into it because health was not being addressed well, was one of the reasons why the government said we've got to really worry about health as an issue, financial protection as an issue, so that things can move forward. There's a lot of other evidence. If you look at, I sit on the board of Reserve Bank of India, one of the things that we worry about greatly is what are people borrowing for? Why are they borrowing at such high costs? What do they do with the money? It turns out somewhere near 20 to 25% of the borrowings at extremely high cost are for health issues. If we had either better health care or we had better health protection, a lot of this high cost emergency borrowing might not actually be there. Right? And again, another direction from the expense side. What about on the income side? What can be done on the income side, and why is that another issue? Why health is quite important? And many of us spoke about demographic dividend. Many speakers earlier mentioned that if you don't have a healthy population, often when you raise this issue, people will tell you, but there are no jobs even for the healthy people. Yes, you need a demographic dividend, you need healthier people, but where are the jobs? If there are no jobs, why are you focusing on creating even healthier and more larger number of healthy people? There are no jobs to be had. I think this misses, some substantive issues on the ground. Right? One of the things we know that as a country, we need to grow much faster. Right? We will not get to the growth, the poverty reduction numbers. 7.5% is better than what used to be called the Hindu rate of growth of 3.5%. But to get to the numbers we need to cross 10, 11%. China, the reason it has been successful at addressing poverty, because it grew at a sustained rate of 10% plus for multi-decades, which is why you see the kind of numbers that we have today, right? We tried in India, and we have tried repeatedly to push growth to that number. What you start to see is hyperinflation. You start to see economy start to creak and croak because it is not able, on the supply side, to respond to these growth challenges. I would argue to you, one of the reasons it's not able to do that is because the human resources that are needed to move forward are not there. There is a new book that has come out by Danny Roderick, some of you might have seen it, that tries to analyze where are the opportunities for growth for countries like India. And it studies 9 countries in this. Right? The core argument it makes is that the opportunity for rapid structural change, moving into export-oriented manufacturing, which is what China did, which is what the East Asian tigers did, that opportunity has come and gone. That opportunity is no longer available to India to achieve the kind of rapid transformation that we expect to see. The only alternative for India is to focus on fundamentals of human capital and look at growth and structural transformation driven by that improvement. We know, for example, rural-urban migration is very important. Right? We know that over a period of time, the benefits of agglomeration are valuable to us as a country. The book argues that without human capital improvements in the rural population, this migration will not produce the outcomes that you want. You may urbanize, but you will not urbanize with the growth dividend that you are expecting to see, or you will get the kind of migration that you are seeing today, which is seasonal back and forth that you're seeing at very low value added benefits. So there are a number of reasons why a country that needs to focus on growth needs actually start to worry about human capital and in particular health as an issue. So I will leave that point there. If there is an interest, we can talk some more about this issue. Moving on to the private sector. One of the things, and there is a new book that has come out in which me and some of my colleagues have written about health as a chapter. And in that general story of what reform did for 25 years since 1991, we strike, I would say not entirely, but somewhat partially, a discordant note in that book. What we argue is that the 91 reforms correctly, perhaps, across sectors, led to a retreat of government in telecom, in transportation, even in banking. You saw a government move backwards, right? And that produced the kind of growth, the kind of development that we need. Telecom is a story that people have spoken about quite a lot. In health, though, we argue that that retreat has not actually been helpful. And retreat in the sense of the absence of growth, the absence of increased participation by the government has not produced the kind of outcomes that we wanted to see. And in fact, one of the states that we highlight for debate is Kerala as a state, in which you start to see from 91 onwards a state in which the private sector has become the dominant, by a wide margin, provider of healthcare services. Right? So clearly, the idea of private sector, in our minds at least, and in my mind at least, is not the absence of government. Right? And that's not how we articulate what I would like to suggest is the role of the private sector. In fact, one of the things that's interesting, and there was a little bit news to me coming from the private sector, that in no country which has successfully built a health system has the government withdrawn from actively participating in the way the health system works. You take rabid private sector economies, Switzerland, Japan. The government is an active, engaged partner. In fact, it is surprising to us, in many of these countries, the way in which the government operates in the health sector is reminiscent of the license control Raj that we so detest now, and we are so pleased that we have withdrawn from it. In health, actually, that is still the dominant mechanism by which the government operates and engages with the private sector. Right? The reality, though, is, and this is something that's obvious, I don't need to tell anybody, the government, given, depending on how you count it, spends 20 to 25% of the total expenditure on health. The 5 billion, the 5 trillion, the 5 lakh crore, 6 lakh crore that is spent on health comes largely from people's private pockets and is spent largely in a variety of, whether there are jholawalas or whether there are government private hospitals, the money is spent largely there. Right? And in some ways one could argue, and one of the examples that I certainly recently came across, we mentioned UP, and I will mention a UP example, is what is going on in UP and what is the role the private sector is playing. And it's an interesting example of what, the manner in which the private sector has actually engaged with the health system in UP, right? Overall, the UP government spends 12,000 crores on healthcare for its large population, giving about 400 to 500 rupees per capita as health expenditure. Right? Total expenditure in UP, though, is 50,000 crores, of which 12,000 crores is an important component, about 2,000 rupees per capita. Right? And that 50,000 crores actually delivers the results that UP sees. And not all of them are necessarily bad. There are, as Mr. Mishra pointed out, if you look at recent history, many parts of India have delivered a reasonable amount of value, and certainly UP is no exception. One could argue it should have done even better, but it certainly has made some progress in that period. But if you look at the contribution of that overall 50,000 crores relative to what the government has spent, look at one particular metric, which is emergency care that is made available to women, And in that, I would use, because that's the only thing for which data is available, cesarean sections, right? In cesarean sections, in the public sector, because of Janani Suraksha Yojana, there has been a huge increase in the number of women that deliver babies in institutions. Cesarean section rates have fallen by more than half in the public sector. They used to be around 11%, now they are under 5% in the public sector. WHO tells us that somewhere near 15% is the number that you should see to get a reasonable set of health outcomes. Clearly, in the public sector, you're seeing a much smaller number. Where are the C-sections taking place? Because the average for UP continues to be a reasonable 10%, it is in the private sector. In fact, I would argue to you that if the private sector was not offering cesarean section services, the maternal mortality rate in UP perhaps would be double what you are seeing it today. Right? Unfortunately, the private sector is not an animal that can be that operates with consistency everywhere. Lucknow, I'm told the numbers of C-section have crossed 45%. Right? And obviously now it is clear that there, what is going on is well beyond what the WHO advises as a reasonable rate. The point I'm trying to make, though, is that there is a role that the private sector is already playing in a state like UP, and some of it is beneficial, some of it is actually not so beneficial. Health, unfortunately, and one of the reasons why in that book that we bemoan the withdrawal of government from health, or not the absence of growth of government in health, is not a sector in which the overall working of the market produces the kind of outcomes that we want on its own. And the C-section story of UP is very much an example of that, right? You allow it to operate, customer demand, and Kerala is another story. Why do you see such high C-sections in Kerala? Because customers demand it. It's not simply that the private sector in Kerala is offering high C-sections. Public sector in Kerala is also offering high C-sections because customers are demanding it, right? A market that, a pure market approach will respond to supply and demand in health can produce sometimes outcomes that are not very beneficial, right? And anybody that intervenes in health has to intervene fully appreciating that the market process will not actually work well, right? One of the thoughts, therefore, would be that if the government is interested in the private sector, we often tend to think of private sector in the PPP mode, purchasing, the public-private partnerships, right? That's clearly one way in which the private sector can be used. The tragedy is that goes back to the same resource base that the government has, which is not that much. Right? 12,000 crores, can it be spent better? One could argue, yes, there is some role for PPPs. One could buy from the private sector. What about the balance 38,000 crores? How do you make sure that that money is spent much better? Right? There are a number of mechanisms that the government has today that can allow the government to actually make sure that the entire 50,000 crores and on the national basis, 3.5 lakh crores is spent much better. But the government will have to then stop thinking, and the Ministry of Health at the state level will have to stop thinking of itself as merely an operator of a public system, but actually somebody, Minister of Civil Aviation comes to mind, as somebody that does not just run one particular airline, but manages the entire sector. What are some of the mechanisms that it has? Price control certainly is a mechanism government is already starting to use for stents. It's starting to talk about knee replacements. It can start to do that across the board. How about, putting price control on cesarean section prices? How about ensuring, Madam Soumya Swaminathan is here, there is work going on to develop a health technology assessment wing. Can it start to specify what processes must be followed to decide C-sections are required or not required? Again, it's a much longer topic of much longer debate of what is the way in which the government can play a role in getting the private sector to perform a beneficial role and back away from the negative role that it plays. All I would argue to you is that in an environment where we are going to have a large private sector, this is going to be essential if you're going to get to our 2030 goals. Thank you very much.
Thank you, Nachiket. Thank you very much for that extremely insightful and thought-provoking discussion. Yes, there's a lot more to be discussed and a lot more to be said. It's not an issue as simple as it appears, whether it is public and private, or public on its own and private on its own, contributing towards the same objective. That's a debate we need to carry on with. Ladies and gentlemen, unfortunately, I've just got the signal that 12:30 was the time and we've already crossed that. So that doesn't leave me with much scope of saying what I wanted to. We'll keep that for some other session. But just to highlight a few points very quickly. First, the critical aspect when we talk about healthcare delivery is that we need to concentrate on the three basic pillars, that is access, affordability, and quality. And that is where healthcare should be headed. And second, and more critical than this is that, as I mentioned earlier, health cannot be government alone. Therefore, we need to find an ideal mix of public-private investment. I largely see government as driving the healthcare delivery system with an entire gap that the government is not able to fill being filled by the private sector in whichever manner be appropriate to that region or to that state. And this is the only way we can actively work towards reducing the out-of-pocket expenditure, which lies close to 58% as on date, which is very, very high, and particularly with reference to the catastrophic expenditure. But the issue I'd like to flag is resources we must increase. We must leverage the private sector resources. Having got the resources, the critical decision that we must take is, where should the resource lie? Without getting into details, my view is that much of this resource must go to primary health care, to preventive and promotive health. It does not make sense, according to me, to go on increasing hospital beds and simultaneously go on increasing the number of patients in the country. Therefore, all policies must converge on getting investment into primary health care. And if you look at the 2017 policy, it says 2/3 of the resources should flow to the primary health care. The next issue that together with this, we also need to look at the issues of health financing. And there are many models in the world. And as far as India is concerned, we need to learn from what is happening across the globe. But let me also place a point before everyone here, that there's a lot of learning within the country also in different parts of the country, which we need to pick up and actually span out across the country with. We do have a very, very, a tough call ahead. At one point of time, we were only talking about communicable diseases. Then we realized that in the maternal child race, we are far behind. We tackled that. And one thing I would stop for a minute to say, yes, there are issues and serious issues with the healthcare delivery system. We all seem to be picking up on all of that. But if you pause as a country for a minute and look at what has happened, it is a cause of worry, all right, but there are many, many bright spots. Unfortunately, I always feel as a country, we've forgotten to celebrate success. I think once in a while we should stop and do that so that the people who are involved in the job get some amount of encouragement and inspiration to keep doing well. And this must happen as a country, not as an individual. I gave you figures and stories about maternal health, child health, or combating. You spoke about AIDS control program or polio or maternal neonatal tetanus, whatever it is. We need to do that. But having been saddled with this, when we talk about India, one critical issue that we must remember is that India is a country with huge amount of geographical inequity. 8 states in the country account for close to 50% of the population and close to 70 to 80% of the entire maternal and infant mortality in this country. Now this brings me to another question. Shouldn't all the investments that we have in the country, at least much of it, lie in these 8 states? Isn't that the best way to get the country ahead? So these are issues we will continue to debate. And I would again urge that whether it is an issue of stepping up public investment or adding private finance to it, or focusing on gender inequities in this country, we do need to have a completely new strategy to come up if we need to redesign our health system. And this is a strategy which will come out of all the wisdom that is here and outside. We need to first and foremost, as a system, recognize our failings. If we are able to do that, perhaps we'll also be able to find solutions to those failings. So thank you very much, ladies and gentlemen. And as always happens, we end up with an apology for all those who had a question in mind, because I'm getting signals from that end that we need to end. So we will say sorry and end by profusely thanking our panelists who've done a great, great job here. So a big round of applause for all the three panelists. Thank you very much, ladies and gentlemen.